Welcome all to this webinar. I'm Wafa El Sadr, and I'm the Global Director for ICAP at Columbia University, and I'm also Executive Vice President for Columbia Global. I also am honored to lead the New York City Pandemic Response Institute. And I'll tell you a little bit about New York City Pandemic Response Institute, or PRI for short. So PRI is a public health resource, brings together diverse organizations, institutions, and communities from across our city to support a cohesive, comprehensive preparedness, response, recovery from any health threats that the community faces. The Pandemic Response Institute is led by ICAP at Columbia University with a key partnership with the CUNY School of Public Health and Public Policy. Today, our topic is preventing a tripledemic of COVID-19, influenza, and respiratory syncytial virus, or RSV. Unfortunately, this tripledemic that took place in winter of 2022, it resulted in more than 100,000 deaths in the United States over just 4 months. We do have effective vaccinations against COVID-19, influenza, and RSV. And I think our discourse today and our conversation today will be focused on highlighting why it is very important to try to prevent these infectious diseases and how we can utilize vaccines effectively to get them to the populations that need them. Now, we're very honored today to have 3 speakers at this webinar, and I'm going to introduce them very briefly, and then you'll hear from them before we go to our panel discussion. I also encourage all of the audience to please put your questions in the Q&A box, and we'll try to get as many questions as possible during the discussion period. So let me start first by presenting briefly Dr. Bindi Crouch, and she currently serves as Assistant Commissioner of the Bureau of Immunization at the New York City Department of Health and Mental Hygiene. She has extensive experience in emergency preparedness and primary healthcare, and has served also in a variety of different roles, including as Director of Adult Immunization Unit and many, many other roles that are very much linked to issues regarding preparedness and protection of populations. Our second speaker will be Dr. Asaida Madad, and she is the Public Health Leader, a Biosecurity Advisor, and she serves as the Senior Director, System-Wide Special Pathogen Program at New York City's Health and Hospitals. And she's also co-principal investigator of New York City's Health and Hospitals Institute of Diseases and Disaster Management. She has extensive experience in the field of preparedness and has focused on all 5 phases of emergency management during her career. Our third speaker that we're honored to have today is Sharanya Pillai. Welcome. And she's the Deputy Director of India Home. And she's been at this Queens-based nonprofit organization since 2018. And she has led major community outreach projects at India Home, including organizations COVID-19 response that reached thousands of community members with education and resources. She's a very strong advocate for South Asian senior rights, and she has testified as to key government officials in an effort to ensure the safety and health and well-being of them. So at this point in time, I'm going to go and invite Dr. Crouch to start with her first presentation, to be followed by Dr. Madad, and then we'll have the panel discussion. Thank you and welcome all.
Great, thank you so much. Good morning, everyone. I'm Bindi Crouch. I'm the Assistant Commissioner for the Bureau of Immunization at the New York City Department of Health. And this morning, I'm just going to give you a very brief surveillance update. So I'm going to start with COVID-19. Okay, so this is data that is available on our website, and this shows the cases of COVID-19 over time, starting back in 2020. I want to point out before we go further that this, of course, is lab-based testing and it does not include home tests. So I think that we need to be sure that we understand that as we're looking at the data presented here, given the number of people that currently use home tests. So we can see the first wave here on the left-hand side, and then as we move along in time, we see that Omicron spike in early 2022, moving through the calendar year of 2023, when we come to the end here, which shows where we are about now. And we just had a very small wave based on the laboratory testing, but we have seen some of the cases over this fall starting to come down. I'm going to show you a little more here. So this actually shows just a close-up for this time period. So going from about the middle of the summer through to about 1 week ago. And this shows our current citywide COVID-19 community transmission. Again, you know, this data, it does get filled in as time moves forward. But you can see that we did have a small, I'll say that it's a small wave, but we did see a small increase in cases, though some of that is starting to come down. But again, these last dates could be filled in later. So this is just showing the most updated table of all of the variants that we're seeing here in New York City. We continue to see variants that are lineages of the XBB variant, and this is important because our newest COVID-19 vaccines, as we know, all have the XBB.1.5 variant within them. So we are seeing now an increase in the HV.1. We're continuing to see the EG.5 here, but you know, you can also follow this. The CDC also follows for the US and shows the variants, the current variants, and we know that these do change over time. This is just some information for the nation. This is COVID-19 hospitalizations by age group. I think it's really important here as we move from left to right, going back just about 15 months ago to the middle of the summer of 22, moving now through October 2023 on the x-axis. We're looking on the y-axis at the hospitalization rate per 100,000. And again, this is across the US. So our bottommost line here in yellow shows our 18 to 49-year-olds. The navy blue is the 50 to 64-year-olds. And then the turquoise at the top is the 65 years and older age category. And we can see that the majority of hospitalizations that continue to occur are in this oldest age group, the 65 years and older. And I think if you were to go and look at some of the other data from CDC, you'd see that we see very similar, but particularly in the 75 years and older also. So here we're kind of showing this. This is COVID-19 deaths by age group in the United States. And on the x-axis here, we see the age of the population, and I'm sorry, on the x-axis, we're seeing percentage, and on the y-axis, we're seeing the various age groups. So starting at the top, if we look at the 0 to 4-year-old category, we see the gray bar representing the percent of the population made up of this age category. And as we move down, we continue to see the percentage of the US population by age group represented by the gray bars, with the percentage of deaths from COVID-19 across the US in the blue bars. And so when we look at this slide overall, we can see that the size of the population begins to decrease when we get to the 65 years and older population, again represented by the gray bars. However, the percentage of deaths due to COVID-19 coming from this age group is substantially larger. So just a quick update on influenza. So this table is all this graph is looking at influenza positive laboratory test results reported to New York City, and this is by season. So if we look at the x-axis, we're looking at time from early November and then going through to the spring and into the middle of May. On the y-axis, we're looking at the number of positive tests reported to the health department, and then each colored line represents a season. And so I'll just take you first to the purple line, which is showing the 2019-2020 season, much of that season happening before we started seeing COVID-19 here in New York City. We can see that we really started to see influenza taking off, starting in about the middle of November, but really increasing all the way through to the end of January, where we see our peak. When we're looking into the 2020-2021 season, that's the blue line at the bottom that stays relatively flat. That certainly is our first full winter season with COVID-19, where we had a lot of restrictions in place. The 2021-2022 season is in green, and that's where we started to see opening up across New York City. And then last year's season, 2022-2023, where we saw an early rise in influenza cases here in the city, and that was also the case across the US. Now you can just make out in the lower left hand, the red marking there, that's New York City this year. And so we are starting out a little bit elevated and starting to track a bit along the yellow line, which is similar to last year, but we will wait to see how things go. Just to note that, we can see more than one peak in one season. And so we did see that in the 21-22 season. So even after we have a wave, we certainly are at risk for having additional waves across the season. And then I'm going to show similar data here for respiratory syncytial virus here in New York City. So again, we're looking at a very similar graph here. On the x-axis, we're looking at time from early October moving through to the middle of May. On the left-hand side, we have number of positive tests reported here in New York City, and then we see each of the respiratory seasons going back to the 2019-2020 season, which is displayed in purple. And I won't belabor and go through all of the seasons since the pandemic. However, I will note last year's season, the 22-23, where we saw the Tripledemic. That is where we saw early rise in RSV cases with a very high peak. You can see that we are now in the red line below where we were in previous below where we were last year, however, starting to climb in a similar fashion to what we did last year. I'm going to stop there because I think we have some additional slides coming from our next speaker. And I'm not sure I think we might be taking questions more towards the end.
Yes, we will take questions at the end, and let's move on to Dr. Madad's presentation next. Thank you.
You can hear me?
Yes.
Perfect. All right. Thank you so much. So first,
do you mind if you put it into presentation mode, Syra, please?
It is in presentation mode, but let's see. Is it not coming up as presentation mode?
Now it is. Perfect. Thank you.
I'll just use this. Perfect. All right.
Thank
Good morning, everyone. So just high level, some of the items I'm going to discuss with you all are threefold. The first is preparing for the upcoming respiratory virus season. I'll first talk briefly about why respiratory viruses spread more in the winter, and then strategies of preventing transmission of these respiratory viruses. Next, I'll talk high level about healthcare response in the 5 S's. So that includes staffing, staff or supplies, space, system and situational awareness. And then lastly, I'll just briefly talk about the importance of health communication, and this includes building confidence in vaccines and therapeutics, and then why it's important to talk to friends, family, loved ones about these prevention strategies. So I'll first start by talking a little bit about the impact of last year's Tripledemic, as the media, coined it. It was obviously a pretty severe respiratory season with, concurrent, implications of these three big viruses, RSV, COVID, and flu, and there was a number of other respiratory viruses circulating at that time. But what I want to show in this particular image here is just the volume of, cases, confirmed cases that we're seeing across a short period of time here in New York City, particularly here at New York City Health and Hospitals. But one thing to note in this figure is that you can see some of the peak timings of all three respiratory viruses. They actually varied, which was good because, while we were seeing concurrent viral activity, the peak of many of these were not happening simultaneously. So RSV started peaking around, mid-November 2022. Influenza peaked around late November into December, and COVID-19 peaked in early November. But from a healthcare standpoint, right, when you start seeing increased levels of patients come through, the impact is still pretty significant. But luckily, the peaks varied across all three. And so we'll see, how this year is going to turn out, because as you know, every year could be pretty different in that sense. So I'm going to get into why respiratory viruses spread more in the winter. And it's important to note that many of these viruses do spread year-round. So flu, for example, does, spread year-round, and you can get infected with flu, throughout spring and summer, if you will. But predominantly, you start seeing flu activity pick up in the winter months. And then particularly even for COVID-19 or SARS-CoV-2, there's no seasonality with it. So it is spreading kind of year-round. But you oftentimes see many of these respiratory viruses spread more in the winter months because of three high-level factors. One is human behavior. People tend to congregate more indoors when it's cold. There have been studies that have shown, for example, during the winter months, people tend to get lonely and they want to socialize more. And so many of these socializations actually happen indoors. And so when you're congregating indoors, particularly when you have poor ventilation with these respiratory viruses, you start seeing more spread in winter months. So human behavior, plays a big factor. The second is the environmental effect on many of these viruses. So respiratory viruses survive longer and transmit more easily in cold, dry air. And so studies have shown temperature and humidity, certainly have an impact on survivability, stability of these viruses, and transmission. And a cold, dry, air, if you will, kind of make it a better condition for transmission of these viruses. And then the last factor is reduced mucosal immunity. So within our own immune response, immunity in our upper respiratory tract is reduced by cold temperature. So the convergence of kind of all three factors play a role in how you see the spread of many of these respiratory viruses happen more in the colder times, for example, fall and winter. So next, it's important to understand your risk and the risk around and those around you. So there's a couple of things I'll highlight. First is host factors. So as an individual, what are items that make you at higher risk for severe illness, whether we're talking about RSV, COVID, or flu? One is your vaccination status. Obviously, we've seen that for those that are vaccinated, their chances of hospitalization is greatly reduced. In fact, if you look at, just as we talk about flu, some of the data that we have that comes out of the Southern Hemisphere, because they have their flu season before ours, has shown that the current flu vaccine efficacy against hospitalization is over 50%, so that's really good news. So vaccination status certainly plays a big role. And then your age, right? So if you are less than 5 or over 60, you're at increased risk for severe illness with many of these respiratory viruses. Your immune system, in terms of if you have a weakened immune system due to disease like cancer, if you're taking medications like chemotherapy, for example, and then any underlying health conditions you may have, like comorbidity, medical conditions, and the like. So these are certain things that can put you at higher risk, or those that are around you at higher risk for these respiratory illnesses. The other is situational factors, right? And this includes if you're going to an event, the situation around you. So this includes like the duration of how long you are talking to somebody. Is it just for a quick 5 seconds? Hey, how are you? Are you actually, having, are you staying there for a longer period of time? And that increases your chances, for example, of getting some of these respiratory viruses, particularly if you are in poorly ventilated spaces. Distance, are you very close or are you kind of further away? Symptom of the individual you're interacting with. So, are they actually coughing, sneezing? Are they symptomatic? And we have obviously seen pre-symptomatic spread of many of these viruses. And then is that individual or are you wearing a mask? And so some of these are situational factors that impact whether or not, you would potentially get infected along with some of these host factors. And then the last is viral virulence and community transmission factors. So what are the type of subvariants circulating in the community? And you just, heard from Dr. Crouch about some of the circulating variants here in New York City. And then community transmission levels. So if you start seeing high levels of community transmission, the likelihood of you interacting with somebody that may be infected certainly goes up, right? So all these different factors impact your risk, you getting infected, as well as those around you. So what are some strategies to prevent transmission of these respiratory viruses? It is a layered approach. You probably heard that a lot during the COVID-19 pandemic. And what that means is that not one layer is 100%. So we want to stack on these layers. Vaccination obviously is really, really important, but it may not prevent, infection altogether. It may prevent you from getting hospitalized or getting really sick or even dying from these respiratory illnesses, but it's not 100%. And that's why you want to layer it on. Getting vaccinated is a really amazing and great strategy. The second is also avoiding close contact with people who are sick. So if you know someone is sick or, is sick or may have been exposed, you may want to avoid close contact with that individual or wear a mask. If you do have to have close contact with that individual, masks work. Well, we have actually new data just out from JAMA that shows how powerful these masks are in terms of preventing transmission. Third is adhering to respiratory etiquette, so covering your cough and the like, using well-fitting masks, as I mentioned, cleaning your hands frequently, avoiding touching your eyes, nose, or mouth, or your mucous membranes, optimizing ventilation, and then practicing other good health habits like getting good sleep. That certainly impacts, your immune system, managing stress, eating nutritious food. All these things certainly go, a great way in terms of preventing transmission of these respiratory viruses. And again, it's a layered approach. So what happens if you are sick with respiratory symptoms and what should you do? The first is you should self-isolate if you can and limit contact with others. And if you do have to come in contact with others, wear a mask, practice respiratory etiquette, consider getting tested for these respiratory viruses, specifically if you're in those extreme ages where you are at higher risk for severe illness, and then seek medical advice. If you are positive, for example, for flu or COVID, we certainly have, treatments depending on, if you're eligible for it and depending on your condition and the like. So certainly seek a, medical advice to see if that's right for you. And then monitor your symptoms. If your symptoms get worse, again, seek medical advice and get the help that you need. So next, I'll just briefly talk about the healthcare response, and I'll talk about it in the framework of the 5 S's, as I've mentioned. So as we talk about the healthcare response, and particularly from last year, while the overwhelming majority of many of these patients had mild illness, just the sheer volume of them had threatened to overwhelm resources and the limited availability for those in need. And so as a result, New York City Health and Hospitals instituted several different strategies aimed at reducing overall demand for acute care services. And I'll talk about some of these, not all of them, and not all of them may have happened last year, but I just kind of gave a snapshot of some of the responses that can happen from a healthcare perspective. So first, our goal was threefold based on last year's Tripledemic. The first is to improve comprehensive situational awareness to support efficient local and system-wide response needs. The second was to decrease demands on acute care resources that were created by the patient surge. And then 3, to increase those resources to care for surging demand, particularly in the areas of staff and supplies. So I'll first talk about situational awareness, real-time monitoring and analytic tools. So this shows you, the number of patients coming in, those are confirmed, those coming in with influenza-like illness and the like. So that was really important. But then obviously interpreting that data was also crucial to see where these trend lines lie and what the forecasting also looks like. And then beyond the analytic tools, you need to couple that with boots on the ground, actually seeing what is actually happening. And so one of the things that Health and Hospitals instituted was this incident command system, where within that they had what we call the pediatric action team, which was made up of pediatricians and ICU physicians and nurses and generalists and the like, and that really helped provide boots on the ground perspective of what was actually happening and how we can tailor some of these responses. And so situational awareness coupled with actual awareness from clinicians was really crucial of understanding what was happening and where we needed to provide some more resources. The next is, for example, from a space perspective, I won't get into staffing. That's pretty, I think many of folks have heard of how you are increasing staffing, but from a space perspective, protocols and processes certainly, have gone a long way. And that includes, for example, for us doing a system-wide risk stratification tool that was developed that set admission criteria and that helps standardize admission decision-making for patients with RSV or other viral syndromes. So that really helps, kind of look at who needs to get admitted in that sense. Stuff or supplies in that sense, looking at obviously what your current inventory is, looking at any spot shortages that were happening. So during last year, you were seeing spot shortages at the national level of certain medications like amoxicillin, as well as certain tools like cribs for babies. So looking at alternate sources and really bringing in supply chain early on in those conversations was really important. And then from a system perspective, I think one of the really important tools that has been utilized is telemedicine. So for us, it's virtual express care and utilizing that to help decrease demand on acute care facilities. And, for those that are coming in for post-visit follow-up, having the option of doing that through telemedicine was really important. And then, making sure you have robust policies and guidances and folks are aware of, what the process is. And the last is communication with patients, staff, visitors, and the public. And really, this is really, really important for folks to understand, what is happening. And if I have these signs and symptoms, what should I do? Do I necessarily go to an emergency department if my child is getting sick, or can I just set up an appointment through virtual express care or telemedicine platform and talk to a provider and see how I can care for my child at home versus actually going to the emergency department. So communicating with patients as well as with staff about what's happening and visitors was really, really important. And the last is, building confidence and addressing, hesitancy. And one thing that you'll hear, probably from our panel discussion is that we have new tools this year beyond obviously the flu vaccine and the updated COVID vaccine. We also have RSV vaccine and monoclonal antibodies, which are really great in our toolbox. And so how do you build confidence in these vaccines as well as these therapeutics that we have, this year? And a couple of strategies that we often employ here within the healthcare system is first leading with empathy and compassion. So anytime we're talking to whether it's a patient or a staff member or the like, it's really leading with empathy and compassion and really understanding, what their needs are and what questions that they have. Motivational interviewing, so asking, open-ended questions and motivating them to also getting, vaccinated. And then using the presumptive approach, which is just assuming that, they do want to get vaccinated and providing information, in that regard and tailoring those conversations based on who they are and what questions they have, validating their concerns and listening really to what their concerns are. Using simple, clear language. So as I mentioned earlier on, as we talk about, vaccine efficacy, with flu, based on the Southern Hemisphere, it was about 50% effective against hospitalization. People may not understand, what does that 50% mean? Does that mean I have a 50% chance of actually getting hospitalized? So maybe not necessarily using the numbers, but using simple and clear language that, by getting your flu vaccine, it really helps, greatly decrease your chance of getting hospitalized, getting really sick, or even dying from flu, right? You don't necessarily have to use many of these numbers that we often see, which are important for us as epidemiologists and those that are working in public health and healthcare, but then communicating that information clearly is also really important. Emphasizing the benefits and then sharing your own story of why you got vaccinated, again, whether it's flu, COVID, RSV, that certainly goes a long way. So these are just different strategies that help build confidence and help address any hesitancy an individual may have. So with that, I will hand it back to Wafa to give it to the next panelist.
Well, thank you very much, Dr. Madad. That was excellent. And I invite all of our panelist speakers to please turn on your video if you're able to, so we can move on to our discussion phase of the webinar today. In the meantime, if you would please enter your questions, and we'll try to take them as we move along. I think let me first bring into the conversation Sharanya Pillai, and tell me, or you can share with us some of the work that you've been doing, in particular at India Home, in terms of reaching the community and disseminating information regarding these the triple threat and availability of vaccines and so on.
Thank you so much, Dr. Wafa. It's been great to be able to be on this panel, and the work of India Home has been we've had essentially a older adult focused work as our core mission for South Asian older adults, but since Census 2020 had built out a community outreach program, and quickly we pivoted to COVID, and since August 2020 have been doing work with the Department of Health and hospitals, first starting with the test and trace program, and it's pivoted into the COVID disparities grant, where we've been working on health equity projects. The work has been very fulfilling and far-reaching. Our target populations are essentially those in Eastern Queens, and Southern Queens, and Central Queens, and
I can't hear you. I can't hear you at all, Sharanya. Can others hear Sharanya?
Oh. Could everyone hear me?
Yes, you are coming in clear.
Okay. I hope that
you can hear her. Okay.
Yeah.
Apologies, maybe something with my connection. I will go out and come back again. Please keep going.
Okay,
Apologies.
no worries. Yeah. So the work that we've been doing recently has been focusing on health equity, but really prioritizing and finding a way to kind of slip in vaccine messaging and resources and education, meeting communities where they're at, given how much fatigue there is prevalent in the community. And for our older adults, the in-reach that we do is very important, given, you saw in the presentations earlier how at risk that they are. And so the work has been really giving continuous messaging in engaging ways. Last week, our CHW did a Jeopardy game to do vaccine education with the seniors, and was like, they really know so much, and having those types of engaging ways of educating the seniors is important. And the tailored outreach has been really important as well. Knowing that we have 5 different locations, and not each location is going to have the same approach. Not each location is going to have the same vaccination status, even though they're all South Asian older adults. There's really, differences within those communities that CBOs like ours we're privy to. And so having that tailored outreach has been really important. And yeah, that's been the work. I hope the audio has been okay.
Thank you. I'm back and I can hear now. Apologies about that.
Perfect.
Yeah, I have maybe going back to Saira, and as you're aware, there are lots of data that show that when the provider recommends something to their patient, that often is well received, and the high likelihood of positive response. And I'm wondering about you raised the issue of kind of, assume that people want to do it, or what we call the opt-out, like that people will opt in if we use that approach. I'm just curious about the healthcare providers at H&H, and how are you trying to mobilize them to try to achieve as high coverage as possible with these vaccines?
So that's an excellent question. So the one thing I'll say is, during the COVID-19 pandemic, we built this really amazing, robust program called Be a COVID-19 Vaccine Champion, and then Be a COVID-19 Vaccine Ambassador. And it was basically training them of how to be better science communicators and how to build confidence in these vaccines. And we actually had over 6,000 people that participated in this program, and we called kind of COVID-19 Vaccine Champions. And they actually went through a curriculum we developed on, as I mentioned, not just about what these vaccines are, but then, how do you actually talk to people in a way that they can understand and the like. So what we actually did is we took the information in terms of who these 6,000 people were, and we asked them, well, besides just for COVID-19 vaccines, would you also want to do this for flu season for flu vaccines? And so what we're doing now is we're starting a new campaign, which is Be a Flu vaccine champion and an RSV vaccine champion. And very similarly, building on those same skill sets, same curriculum, how do you effectively talk to patients and make sure that they understand why it's so important? And as you mentioned, having that clinician's recommendation goes a very, very long way. It's probably one of the strongest indicators of individuals actually getting vaccinated is if their clinician is strongly recommending it. They know that the clinician is there to help them because that's why they're going to seek healthcare services. And so having that strong recommendation certainly goes a long way. And that is part of our curriculum. So we are building a new program that's going to basically piggyback up our COVID-19 vaccine champion and help educate them with some of these communication skills. Because while you may know the data and you may know why it's so important, it's that communication skill that's so important, and bringing in some of these behavioral scientists that have done a phenomenal job sharing some of those skills of these words resonate more with individuals versus those words, right? Positive framing versus negative framing. Those things are really important to kind of share.
Great, thank you. That sounds like a very interesting program. And maybe now going to Dr. Crouch, I'm curious in terms of, you showed the data about specific populations at risk, very young, very old, older people, and that's relevant to Ms. Pillai's work. But what about reaching some of the other vulnerable populations in our midst? For example, obviously the children, obviously elderly individuals, but also the homeless shelters, and maybe immunosuppressed patients, individuals. How do you think about reaching, how does the Department of Health and your program think about reaching those types of populations?
So I guess I'm just going to thank you for that. I'm going to dovetail really on what Sarah had suggested. And I think at this time, we've had a lot of mass media and media campaigns on vaccination for both COVID-19 as well as flu vaccination, and now also going into RSV immunization products. So I think that what is still needed is that one-on-one conversations between the patient and their provider or other trusted messenger. So I think the program that Sarah laid out is, a very good way for us to be going. But for our clinicians, in particular for our children, we'll start there. I get a lot of concerns from parents contacting the health department because their pediatrician is not carrying COVID vaccine and trying to understand where they can get it. And I think here in New York State, the pharmacists are able to vaccinate children against COVID-19 and flu. And for flu, it's down to age 2, though different pharmacies will choose different lower age limits just based on what their comfort level is. And for COVID vaccination, it's down to age 3, but similar, that the pharmacies will choose the lower age limit. But we are seeing so much vaccination done in the pharmacies now, but really it leaves out these youngest children. I will say that about 75% of children here in New York City are eligible for vaccine offered through the Vaccines for Children program. And that vaccine, of course, for all of our VFC providers is no cost to the provider. So we really are encouraging trying to encourage at this point all of our VFC providers to ensure that they have vaccine available, especially for this younger age group. As part of the requirements for the VFC program, providers have to have all recommended vaccines available. And so it is a requirement of the VFC program. And I think, given that 75% of our children are eligible, we really need to see our healthcare providers ordering vaccine and ensuring they have it on hand at the site of the well child visit. I would say that, also for children and really setting you up for a lifetime, I think that we're looking forward to doing more work with obstetricians around the city. Probably the best time to start talking about pediatric vaccination is when the person is pregnant, so that they can begin making those decisions before they even present to the pediatrician with their child. So again, these one-on-one conversations, talking about safety, dispelling myths, I think that these are extremely important. I just want to relay one thing. You know, I was at a conference and we had two anti-vaxxers, two mothers, anti-vaxxers, who had become pro-vaccination. And one thing that they pointed out that I thought was extremely enlightening to me, but maybe not to parents. But you know, they mentioned that they had never set out to be anti-vaxxers. But when they gave birth to their children, it was a very stressful time and also a very lonely time. And when they were using social media, and this is literally what they told us, using social media, they just found a community in the anti-vaxxer group, and all they were looking for was support. They ended up finding it within the anti-vax groups, but really they had not set out for that. So they talked a lot about the social support that their providers could have provided to them, both on the OB side, but also as new mothers in the pediatric office. So I think that we really have to take a lesson from that and consider, what do people need overall for their well-being? How can we ensure that it's people who are pro-vax, who can give strong recommendations, that are also providing support for loneliness, difficulty feeding your child, these types of things. So I'll say that on the pediatric side, and we have had various programs for other prioritized populations. I think with funding, decreases in funding, we're not able to do a lot of those programs, but I do think it is still, it's time to move into those one-on-one conversations. I don't think that anything that we're going to do in mass media is going to change people's mind who have decided not to be vaccinated. I think what can do it is those one-on-one conversations.
Well, thank you very much. And I do appreciate that during the COVID-19, the height of COVID-19, I think there were all these innovations, going, I always say, going to where the person is rather than waiting for them to come to us. And, and I think I do hope that we can retain some of those innovations, because I think they yielded some good results. Let me now turn to Ms. Pillai and ask you a question. I am very intrigued by your work with seniors in particular, and I would imagine that in your conversations with the seniors and your support of this population, that often you may have an opportunity to reach the children or the grandchildren. And I'm just curious how much of your communication around these issues center not just around their own care, but their role as well as matriarchs and patriarchs and within families, and how can they influence uptake of vaccines and healthy behaviors amongst their children and grandchildren.
Yeah, definitely. And to the earlier question as well, I know we had a relevant event for the homeless population where we brought vaccines to a homeless shelter, and a big part that helped give that additional push was to give incentives. And I know funding is limited across the board, but to use some of our funds to give, a gift card was actually the kind of that factor that gave that additional push, which was helpful. So I just wanted to make that plug there. For the grandkids and other family members of our older adults, the focus has been on the vaccination status of the older adults, but we've been given, we do make it a point to give collateral that they can take home to their families, and the Department of Health has created really great collateral as well. It isn't a one-size-fits-all approach for sure. One of our centers is we have more of intergenerational households where they do live with their grandkids. And so we make it more of a point there to conduct the outreach or provide collateral and messaging, and also invite their community, their family members to come to our vaccine sites. So those days that we have the vaccinations, we don't just have it only for our older adults at the centers. We say, you know, if your kid is there, if your grandkid, when we do have those vaccines available, we do invite them to visit our locations and to take those vaccines themselves. We don't provide that age limitation on those sites, though our, you know, center services are for age 60 plus. So definitely that has been, you know, our one of our approaches for engaging our existing population. And for our outreach in the community, we've been doing, you know, pediatric outreach as well. So providing tailored messaging, children's masks, and coloring books, and those kinds of things to engage like the younger population, and meaningfully having those conversations with the parents has been important for our outreach team. So yeah.
Great, thank you. And maybe I'll go back to Dr. Madad and ask you a question. And in my experience as a healthcare provider, I'm an alum or a veteran of H&H, having worked there from one of the hospitals for many years. I was always intrigued when the patient came in to see me and said, "Oh, they're talking in the waiting room about the vaccine. Should I get that?" And I feel like there's it's helpful to try almost envelop our recipients of care with messaging from the provider, but also messaging from directly to the recipients of care themselves. So I'm wondering how you're thinking about that kind of approach.
Well, again, another excellent question. And you know, one of the programs that we have within you know, our department is we're very much looking at better health communication, because you can never have good health communication. You need to continue to improve it, right? Especially with today's day and age, with digital technologies, there's more and more innovation that's happening for you to share information with patients. I would say one of the most important ways of helping communicate information is visual signages, right? Or something on the TV screen. As low-hanging fruit as they may seem, those certainly make a big impact, because as you're mentioning, as you're waiting in the waiting room, oftentimes you're looking at screens, whatever's playing, and if they have a message about X, Y, and Z, maybe that's another way for you to get educated, and maybe even ask your provider questions of, "Hey, I saw this on the screen, should I do X, Y, and Z?" So utilizing some of those technology low-hanging fruit. So I can share that at least I think with healthcare systems generally, you see these TV monitors, and some of them certainly have these public health messaging. One of the things we're actually working on, this is relatively new, we have a CDC grant where we're looking at better communicating information as it relates to infectious diseases, not just to patients, but also to our own staff members, saying, "Hey, flu season is here. Did you get your flu shot?" And make sure you promote flu vaccines to your patients. So one of the things we're looking to do is strategically place digital monitors in break rooms, right? Because clinicians, they have to eat. Everybody has to eat. So when you're eating, a lot of times if you're not on your phone, which 90% of us are while we're eating, if we're not talking to somebody, maybe you have the TV running and you can provide some messaging to your own staff members at that time. So we're actually looking to invest in digital monitors that we can strategically place in break rooms. That way we can educate our staff of, "Hey, flu season is here or is approaching. Now is the best time to get your flu vaccine." Or, "Did you know that there's a new RSV vaccine for people that are 32 to 36 weeks pregnant, and it's important for you to promote it, especially if you obviously are patient-facing in the OBGYN clinics," right? So tailoring some of those messages more also to staff and then also to patients. So those are some of the strategies I think certainly we're working on, and that I think certainly do work.
Great, thank you. And again, I encourage the audience to please send us your questions. And let me go to Dr. Crouch. And data are very important, and you showed, both of you actually, Dr. Crouch and Dr. Madad showed very, very informative data. And at PRI, we're very interested in how do we take these amazing data that are at our fingertips as public health or as providers, and then somehow enable community groups to get access to the data, and maybe find creative ways of visualizing the data better, so that community members can in a snapshot, kind of get what those curves are all showing. And I'm just curious, your thoughts in terms of how can we use data more? How can we use data in a way that can reach a broader audience that we would like to reach?
Thank you for that. I don't think you're going to love my initial answer because it's not something that we can do instantaneously. But I think, first and foremost is that in our education, we need to talk about science starting from a very young age. We have to talk about data, and how to look at graphs. I think that that's where it all starts. But again, it's not an extremely satisfying answer because it's not something that we can do this instant. But I will say that, we often are hesitant to use data in our messaging because of concerns about public health or healthcare literacy, which I think is absolutely true. But I do want to point out, and again, and this is going to be anecdotal, not based on data, but I do want to point out that I was in a listening in on a focus group this fall, just about COVID-19 vaccination campaigns. And one thing that we heard from people was that we're showing them some campaigns and they're telling us that it doesn't have enough information for them. They want to know how many people died, how many people continue to die, how many people were, who were, how many people were vaccinated. So this is the type of thing that that people actually want to hear. And I do think that we can use very straightforward numbers to provide information to the public. I know that people got very used to having access to immunization data, and we are working on public-facing immunization data dashboards for New York City so that people can actually look at those dashboards and see what coverage is like across the city. We find it extremely helpful to provide to our physicians because, as physicians, we always think that all of our patients have been vaccinated. And then when we look at the data, we know that that's not clear. But, I do think that data plays a role. I think things like the dashboard can be helpful. I do think, everyone became a public health expert during COVID, but we should really tag on to that now that people have more vaccine awareness, but it's about making sure that it's not the disinformation and misinformation that's out there. So if we can continue to put things out, that's very helpful. I'll make a plug for immunization data, just saying that, in New York State, reporting doses to our citywide immunization registry is sort of an opt-in, in that you have to have consent, and so without that, we don't have the best data to provide for adult vaccination, though we do for pediatric vaccination. So I'll make a plug for people to advocate for that. But I guess that's
very helpful. Thank you. At PRI, we do have one of our core groups is focused on data and not just thinking about how to pull together diverse data and look at triangulating data, but also how can we share data, visualize data better, particularly with communities, and get their feedback and so on, along the lines of what you just said. And I'll move on to Ms. Pillai, and just I do agree, that one of the silver linings of COVID-19 is a stronger appreciation of the value of adult vaccination. Certainly, most people had focused almost exclusively, and most attention has been paid, unfortunately, only to childhood vaccination. But now there is a broader appreciation of adult vaccination, a broader appreciation, I believe, by the public of the vulnerability of older individuals. and so on. But I'm just curious from your experience, have there been, what are the lessons that can you talk about maybe two positive lessons and maybe two things that you didn't appreciate that you learned through your community efforts?
Yeah. So two positives. I think being able to see the changes in people's perceptions over time, similar to, anecdotes of folks that were anti-vax, and seeing the value of testimonials and hearing, this was my friend who I see at center, and she's telling me about this very personal story that impacted her family, and our community health workers, and advocating for and providing those personal stories. It's been great to see the type of impact that has. It's also, we're fortunate to have partnerships with local pharmacies as well, to be able to bring the vaccinations directly to events. Like we have a big Diwali event and Navaratri and a lot of holidays and things. And we can't expect people not to gather, right, during these holidays. And so really being able to have those partnerships has been fortunate. In terms of two, is it about, I'm trying to think of what negative things.
Something that surprised you that you would have, you worked with this community, but something that kind of you wouldn't, without talking to people, you would have never appreciated it. Yeah.
Well, I can say maybe two challenges, if I may.
Like yes, of course.
I think there's obviously the misinformation, and also just the readiness and the quickness with which people get information to their phones. Like everyone, as I said, is a public health expert. They get the information to their WhatsApp, to their phone very quickly. And so like we're just navigating these articles that's come out recently about the risks of providing COVID and flu vaccine at the same time in older adults. So we're seeing that, we're getting questions about that. Navigating that with the immediacy and the urgency that there is when we get findings like that from news articles is definitely a challenge. So definitely do appreciate getting quick data from the Department of Health, and sometimes we just need it so immediately. So that has been a bit of a challenge, being able to address those types of news stories that we see. And I guess another thing that I've appreciated is just seeing how diverse communities, how we can employ strategies that are tailored to not their vaccination status, and also their like cultures, their religions, and really seeing how intersectional experiences, you have to meet them where they're at, and really think about those individual conversations in a meaningful way. And that's the stage where we're at, where we do have to address all aspects of the person, including if they're thinking about their livelihood, they need to pay rent, and thinking about those aspects in conjunction with their vaccination. So putting that, outreach together has been really important, looking at it holistically in terms of all of their health needs.
Great, thank you. I know we're running out of time, but maybe we can just ask a question, and a quick answer would be great. Obviously, the experience with COVID, and all of us are conscious of the inequities that exist in our health system and health services and so on. And just to go around and quickly maybe address how each of you is trying to address some of those inequities. And maybe I'll start with Dr. Madad and then go to Dr. Crouch and end with Ms. Pillai.
Yeah, it's a really important question. And in fact, we're publishing a paper on our experience with the Tripledemic. And one of the sections that we wrote was the health disparities seen during the Tripledemic. And I want to highlight two things in particular. One is that at the national level, first, when we talk about inequities, the same inequities you saw of putting people at risk for COVID-19 are the same inequities that you see from a pediatric perspective when it came to RSV. Socioeconomic status, proficiency in speaking English, and access to healthcare. And one thing that you would be able to see if you look at the CDC website and the national trends is RSV-related hospitalizations for Hispanic patients of all ages were consistently higher than non-Hispanic patients throughout the respiratory illness surge. So that's just on RSV, and we saw that significant health inequity. The one thing I'll also mention on vaccination, particularly with flu vaccines, this is where we need to do a much better job. And this is something that we've been providing from a health system perspective on some of our providers to make sure they're aware of it, is that first, only 1 in 2 Americans got a flu vaccine during the 2021-2022 flu season. And of that, less than 43% of Black, Hispanic, and American Indian, Alaskan Native adults were vaccinated during that flu season. And in addition, as you talk about hospitalizations, flu hospitalization rates were nearly 80% higher among Black adults than white adults from the 2009-2022 flu season. And these are data that I'm pulling from the CDC website, and I can drop the links. So basically, what I'm just doing is highlighting that there are health disparities that exist. People have known about it, particularly from COVID-19, but these are things that have existed way before. And it has translated into the same health disparities that we're seeing with RSV, as well as with vaccination rates. So we certainly need to do a much better job, both in terms of communicating and providing access and resources, particularly to those that are most marginalized and getting impacted.
Great, thank you. And if we can get a quick response from Dr. Crouch. Yes, please.
Sure. Thank you for that. And I think I'm going to try to make it brief. But I guess two really clear things here is that we learned from COVID. The first is that while COVID was a worldwide emergency and we needed to save lives quickly, I think that we have to be very careful in public health and government that we don't substitute the swiftness and quickness of a response for the ensuring that it's an equitable response. So we know, and I know that a lot of people on this very webinar probably have provided comments to us just in terms of ensuring that we save vaccine for slower administration to communities that were particularly impacted in particular our BIPOC communities. And then second, I'll just say that I think that it can be very challenging for those of us who work in government to really communicate what equity means, that it is not equality, and that we do need to do interventions that are for particular communities. And that does not mean that we need to do the same intervention for all communities. So if we're going to do a pop-up, for instance, if we need to do it at our schools where there's been less access to immunization, but not at schools where we know that people are accessing immunization well, then that is what we need to do to ensure equitable access. But I think I know that we really like to use the word, and it's a very popular word these days, but it can be uncomfortable for people to really choose equity over equality. And so I think that's something that as public health providers, we need to learn how to communicate better and prepare people for the next emergency.
Thank you. Okay, thank you very much for your insights. And Ms. Pillai?
A big part of equity for us, we're trying to reach the communities in Eastern Queens and Southern Queens, Central Queens. And so that's not all South Asian, right? So we have a very diverse team, and we had to really think about what are the communities that we need to be seeing in our staffing and recognizing, the increased costs of providing culturally competent and responsive care. And so that also has meant, taking the time of our staff members that speak, 15 languages, really getting, even if it's our program coordinator who's at the center, but happens to know that language, if we know that a translation of this collateral is important, we get them to do that, and really pulling into our resources, recognizing, the importance of having translations to reach the diverse communities in the area.
Great. Thank you. Thank you very much. And I really want to express my appreciation for all of our speakers today. Thank you very much for sharing all your knowledge and information and experiences with the audience. And I know that it's going to take all of us doing our very best to be able to get the coverage in terms of these very effective vaccines amongst our community members. So thank you for all your efforts, and we'll see you again on our next webinar. Have a good day, everyone.
Thank you.
Thank you.